are pleased to welcome you to this edition of Patient Pulse with Dr. Seth Martin, who will be discussing My LDL is Off the Charts, What Should I Do? An update on cholesterol lowering options. Dr. Martin is a preventive cardiologist and clinical lipidologist at Johns Hopkins Hospital in Baltimore, Maryland. He's a core faculty member in the Ciccarone Center for the Prevention of Cardiovascular Disease, where he directs the Advanced Lipid Disorders Program and Health Technology Innovation. As a prolific researcher and innovator, Dr. Martin led the development of a more precise system for estimating LDL cholesterol, and he has published more than 200 articles in leading cardiology and medicine journals. He also serves as the associate editor for the American College of Cardiology's Dyslipidemia Clinical Community, and he's an associate editor for the Journal of Clinical Lipidology. So Dr. Martin, we're so pleased to have you for this episode of Patient Pulse, and take it away.
Aviva, thank you so much. It's a pleasure to join, and thank you to all that are listening. This is a topic that is near and dear to me, cholesterol lowering options. Here are my disclosures. So before we dive into the details, let's start with the basics, cholesterol 101. First, cholesterol can be found in all the body's cells. Secondly, your liver makes it, and it's also found in certain foods. Really importantly, too much cholesterol in the blood raises the risk of coronary artery disease or heart disease, which can lead to heart attack. So let's talk a little bit more about that plaque. The medical term we use is atherosclerosis. This is buildup of the cholesterol and other material from these inflammatory molecules that cause plaque in the heart walls and arteries. So this buildup of plaque in the heart walls and arteries can lead then to cardiovascular events in other parts of your body. There's a medical term that's become quite common over the last decade in our guidelines called ASCVD, standing for atherosclerotic cardiovascular disease. The reason for that is that some cardiovascular diseases are not primarily due to buildup of plaque, they're due to other causes. And so this is really distinguishing the types of cardiovascular diseases like heart attacks that result from that plaque, and then that has implications for what treatments work. Familial hypercholesterolemia is really important. This is a genetic disorder that makes the body unable to remove LDL cholesterol from the blood. So the liver is not working normally to remove that bad cholesterol from the blood. And this is much more common than is often realized. Although a genetic disorder, this is present in over 1 million Americans and unfortunately under-recognized. So something important for us to all continue to learn more about and better treat as a country. LDL cholesterol, this is sometimes called bad cholesterol because it can build up in your arteries. This is really the type of cholesterol that we know a lot about, how bad it can be in terms of causing cardiovascular disease, but we also know a lot about how we can lower it with lifestyle and medications to improve patient outcomes. In preventive cardiology, we often use these terms primary and secondary prevention. The term primary refers to preventing or delaying onset of heart disease. So these are individuals who have hypertension, high cholesterol, have diabetes, basically have risk factors for developing heart disease. And the goal is to address those risk factors to prevent disease. Secondary prevention, basically strategies to reduce the chances of a recurrent cardiac event in patients who have known heart disease. So this is patients who've been in the hospital with a heart attack, and now we're starting cholesterol lowering therapy and other therapies to reduce the chances of something happening again. I've already mentioned lifestyle, and this really is the best medicine. Although we have very effective medicines, and we're going to talk about those, the treatment of ASCVD starts with a healthy lifestyle. This reduces ASCVD risk at all stages. In younger individuals, healthy lifestyle can reduce development of risk factors and is the foundation of ASCVD risk reduction. In all age groups, lifestyle therapy is the primary intervention for metabolic syndrome. These are statements from our 2018 American Heart Association, American College of Cardiology multi-society guidelines. on management of blood cholesterol. So acknowledging that lifestyle is where we start, statins are very effective and safe medicines that are helpful to many, many people in addition to the healthy lifestyle. And the way statins work is they block a substance in your body that is needed to make cholesterol. This happens in the liver. As we block this pathway in your body, this then triggers the liver to put out more of the receptors that remove cholesterol from your body. And statins have been shown in many high quality trials to lower the risk of heart disease and stroke. And over the years, they've been studied very, very well. And in fact, we have 7 different statins that are currently available on the market. And here are the names of them listed. Rosuvastatin and atorvastatin are the 2 that are commonly used. In subsequent slides, we're actually going to talk some about statin intensity. So I'll just preface that by saying that rosuvastatin and atorvastatin are the 2 statins that can be at the higher doses would qualify as high intensity statin therapy. Those are the most effective at lowering LDL and lowering risk. But lower doses of those 2 medicines, as well as these other statins, simvastatin, pravastatin, lovastatin, fluvastatin, and pitavastatin, can also be effective and would qualify in the moderate or low intensity statin categories. And we'll talk some more about that. So these concepts of high intensity, moderate intensity, and low intensity statins were introduced in our American Heart Association and American College of Cardiology guidelines. And they're useful concepts because they help us understand how the combination of a certain statin type and the dose will translate into its effects. So I mentioned that in terms of high intensity, the only 2 statins that would land in that category are rosuvastatin and atorvastatin. Specifically, a dose of 40 to 80 milligrams of atorvastatin or a dose of 20 to 40 milligrams of rosuvastatin. It's basically the statin type plus the dose that determines what intensity you have. And those types of statins and doses that are qualifying as high intensity would be expected to reduce your LDL cholesterol 50% or more. So cut it in half from where you're starting. So if you have an LDL of 160, you'd expect it now to come down by 80 milligrams per deciliter with those regimens of statins or more. And so this is helpful because it gives us a sense of where to expect the response to be in LDL cholesterol. Even though everyone's different, we're not all going to have exactly the same response. It gives us a ballpark to look for. Moderate intensity statins would tend to be in the 35% to less than 50% range. And many different statins would qualify in that, either lower doses of rosuvastatin or atorvastatin or a bunch of other types of statins that were listed. It's not very common that we use low intensity statin therapy. But if someone's had a lot of trouble with higher intensity regimens of statin therapy, then a low intensity regimen might be used. So let's get into some charts from the guidelines. When you first glance at this, it looks kind of busy, but it's really intuitive. This is from our AHA/ACC guidelines, who should be on statin for primary prevention. So we have some bullets along the side to help kind of walk through the diagram. And so the first bullet is you should be on a statin if you have LDL 190 or more or diabetes. And that's seen on top right-hand part of the slide, that if you're in that category of LDL 190 or more, or you have diabetes and your age is 40 to 75, these are marked green. These are class 1, the strongest recommendations to be on a statin in the primary prevention setting. And then in the patients who have diabetes and in that age category, a risk assessment can be done using the pooled cohort equations to determine if a high intensity statin therapy may be indicated as compared with moderate intensity statin therapy. If you don't have one of these conditions, then we start to flow down through this chart. And so if one is 40 to 75 years of age and has an LDL cholesterol of 70 to 190, then you move down into this part where we do a risk assessment by the pooled cohort equations. And that estimated ASCVD risk is determined by looking at your age, your blood pressure, whether you have been smoking cigarettes or not, your cholesterol numbers, whether you have diabetes or not. Those traditional risk factors are used to estimate this risk. And then, very importantly, and we'll talk more about that, it then doesn't trigger an automatic decision. It really informs a discussion between you as the patient and your clinician to use that risk, plus possibly looking at other risk answers or factors such as coronary artery calcium that can be measured by a radiology scan to ultimately make a decision if therapy is right for you. So this is more of the art of medicine. It's a shared decision based on all that information, whereas it's a more clear decision in the setting of LDL 190 or more in diabetes. Let's look a little bit more at some of the underlying data for statins in primary prevention. This is one of the landmark studies in the field, the Jupiter trial led by Paul Ridker. And here, rosuvastatin was tested compared to placebo in patients who had risk factors for cardiovascular disease but had not had events. And there was a 44% relative risk reduction, and there was a 1.2% absolute risk reduction, just subtracting 1.6 from 2.8 in patients who were treated with rosuvastatin versus placebo in the primary prevention setting. So this is one of the trials that provides direct evidence for the benefits of statin therapy in reducing cardiovascular events in patients with primary prevention. You may ask, well, why push to such higher doses? Why is a higher dose or intensity better than lower intensity? And this is really one of the key summaries of all the data from the cholesterol treatment trialists. And what it looks at here is all of the clinical trials. I showed you a slide from Jupiter, but there's been many clinical trials of statin therapy over the decades. And what the cholesterol treatment trials have done is summarize all that information together. And then what's being presented here is how much the risk is reduced for every millimole reduction in LDL. And a millimole in our US units is equivalent to 39 milligrams per deciliter. And as I mentioned, of LDL reduction will depend on having more or less statin therapy. And so what we see here is that there's this consistent about 25% risk reduction for each 39 milligram per deciliter lowering of LDL. And we're seeing this for, it says coronary events, so heart attack events, revascularization, meaning needing stenting or bypass surgery procedures, and also stroke. And so this consistent reduction across different types of patients within the trials where more intensity is the winner. The categories here are non-fatal MI and CHD death, and this is bypass surgery and stenting, and these are strokes. But all these different categories, consistent reduction. And so the more intensity of statin you use, the more LDL reduction you're going to get and the more relative risk reduction. So if you get instead of 39, you get a 78 milligram per deciliter LDL lowering, you'd now expect closer to a 50% reduction in your cardiovascular risk. And given that statins have been shown to be very safe, this is very attractive proposition to use a higher intensity statin to get more benefit. So we had talked about primary prevention versus secondary prevention. And so the top categories here are looking at that. We have coronary heart disease or other types of vascular disease or none, which is basically the primary prevention group. And again, we see consistent benefits whether patients have diabetes or don't, whether they're men or women, whether they're older or younger, we see these consistent benefits. And so the guidelines would, in certain primary prevention contexts, want at least moderate, but often high intensity, and especially in secondary prevention, which we're going to talk about, high intensity would be preferred. We're lucky now to have additional non-statin medicines that have really emerged over the last decade. For a long time, it was starting to be questioned whether anything was going to work other than statins. And so we finally got the IMPROVE-IT trial results of ezetimibe. And this is an oral medicine that prevents cholesterol absorption in your intestine. And it's used alone or in combination with a statin. PCSK9 inhibitors are injectable medications that decrease LDL in your blood, and they're used with diet alone or with other cholesterol-lowering medicines. So these medicines are added ideally to lifestyle and statin therapy, and they both, we believe, tell the liver to work better, similar to statins, although they work by different mechanisms. Ultimately, your liver will do a better job cleaning out the LDL garbage from the blood. And these medicines are particularly important in secondary prevention. So here's the flow chart from the guidelines on secondary prevention. The first bullet, if you have ASCVD, then you should ideally be on a high intensity statin therapy. And so that's what I had already said. So then, depending on your treated LDL, very high risk, ezetimibe and PCSK9 inhibitors would be considered. Of course, healthy style is right under the clinical ASCVD box. If we follow down the right-hand part of the chart, very high risk ASCVD, we start with that high intensity statin, and then there's consideration of the other agents. And so if the LDL is 70 or more on statin therapy and optimal lifestyle, we then add ezetimibe. There's a strong preference here in the guidelines that if a PCSK9 inhibitor is being considered, to add ezetimibe first and then consider the PCSK9 inhibitor. And then when we get down to the bottom right-hand box, in patients who are already on max statin therapy and plus minus ezetimibe, the PCSK9 inhibitor would be considered if the LDL is 70 or more, and that's a 2A recommendation. So in my practice, I certainly follow this and will be considering that 2A recommendation to be something that I should strongly consider with my patients and work to escalate therapy until we get that LDL better controlled. This is in the very high risk category, and that we have a brief note here at the bottom would include a patient who's had recurrent ASCVD events, so has had multiple heart attacks, or has had one ASCVD event and has high risk conditions. And there's a number of high risk conditions such as age or hypertension or other factors that would put someone into a high risk category. It's probably going to be about half and half of a stable clinical ASCVD population that has very high risk and another half that doesn't. Whereas folks that have had a recent event are more likely to be in the very high risk category. So if we go to the left-hand part of the slide, the recommendations are similar, but in terms of the non-statin therapy that's recommended to be used, it really stops at ezetimibe in the group that's not very high risk. And so if the patient is in this age category on high intensity statin therapy and their LDL is still 70 or more, would consider adding ezetimibe, and that's a class 2B recommendation. There are new drugs in addition to ezetimibe and PCSK9 inhibitors that we should mention. So bempedoic acid is an oral non-statin LDL lowering medicine used in patients with familial hypercholesterolemia or established ASCVD requiring more LDL lowering. It's been FDA approved just recently in February. And then coming through the pipeline is inclisiran, which is another PCSK9 inhibitor that actually works by stopping the production of PCSK9. And in 3 large randomized controlled trials, it had reduced LDL about 40% in patients with FH and approximately 50% in those with ASCVD. So the large trials to show that this drug reduces events for inclisiran actually as well as for bempedoic acid are ongoing. In the meantime, these drugs have promising data in terms of their LDL lowering and safety effects in the clinical trials that have already been completed. So we've talked a lot about the medicines, the clinical data, but often it comes down to very practical issues, whether these medicines can be used in practice. And so in terms of cost and insurance barriers, I thought this would be important to touch upon. GoodRx is an online source for prices. And many of you may have already used that. You can see how the price can vary from different pharmacies and just know what a price is that you can pay. And sometimes there's coupons that can be helpful to bring down out-of-pocket costs for drugs. So a good resource to use. Fortunately, statins and ezetimibe are both generic and often less than $10 per month. PCSK9 inhibitors are newer and more expensive. They've come down in price, but still often require prior authorizations, and co-payments will vary by insurance. And so this is a changing landscape. We are hopeful that it's continuing to get better, but this may require even more effort on the part of the clinician as well as the patient to secure approval for this therapy and to figure out ways to help reduce the payment of it after. And some patients do qualify for copay cards that can help reduce the out-of-pocket costs. Shared decision-making is really important, something I'm very passionate about. We've written paper that was published in the Journal of American College of Cardiology, really, even before the latest guidelines came out. This was something we had written as sort of after the 2013 guidelines, just highlighting the critical importance of shared decision-making, of empowering patients to make decisions that are best for them. And we as the clinicians are really there as a guide through the evidence to find a treatment strategy that fits with our patients' goals and preferences. And so although we're all busy and clinic appointments can be, short, that we need to find time to prioritize this, that patients and clinicians should have time for a risk discussion prior to starting cholesterol therapy. And this conversation covers your major risk factors. We think when starting cholesterol therapy, it's important to understand, here are my risk factors and how does the cholesterol lowering therapy relate to managing my risk? The potential benefits of lifestyle and the drug therapies that are being proposed, any potential side effects and drug-drug interactions, cost information, preparing for that and trying to avert any potential barriers to therapy because of cost, and the values and preferences of a patient. For example, if a patient says to me, I have this really strong family history and I know my risk is borderline, but I don't think my family history is being taken into account fully, and I really want to do everything I can do to lower my risk, that signals to me a very strong preference to start cholesterol lowering therapy in addition to lifestyle as early as possible to lower that cardiovascular risk. Whereas I may see another patient who has just a lot going on in their medical care, their life, and cholesterol lowering therapy at that particular moment is not a top priority for them. And the decision may be, well, let's get back together in 3 months or 6 months and see where we're at and revisit this. And personalizing this decision making is important because a lot of times the decisions to prescribe cholesterol therapy can be made without enough discussion, and then there's not the buy-in of the patient to take it. And we know non-adherence to therapy is a huge problem. And so doing this conversation up front to really have the clear mutual understanding between the clinician and patient as to why therapy is being prescribed and these details, I think, can help with that buy-in and promoting long-term adherence and kind of doing things right up front. But this can be an ongoing conversation through multiple medical visits. And then the same kind of discussion can be used for adjustments to therapy over time. So the bottom line is that too much cholesterol in the blood contributes to atherosclerosis and raises the risk of heart disease. It's really about the long-term exposure to LDL, bad cholesterol, that causes that disease. And a healthy lifestyle is absolutely the foundation of cholesterol risk reduction. For patients who've not had any heart attacks or strokes, any cardiovascular events, we consider this to be primary prevention, and our goal to be preventing ideally, or at a minimum delaying the onset of disease. Whereas secondary prevention is the model that we use for patients who've already had a cardiovascular event, and now our goal is to reduce recurrent events in patients with that known disease, and really to make it the first and only time that they ever have an event. To do that, we need to use lifestyle, but also use well-established cholesterol-lowering therapies, statins being foremost, as safe, effective, and low-cost option. But we're now very fortunate to have multiple non-statin options when lifestyle changes and statins aren't enough. And ultimately, it's about that partnership between the patient and the clinician to apply the evidence in a way that fits with the patient's life, and to use medicines that are affordable to the patient, and to monitor the treatment effects over time, and to make sure that no side effects are occurring. So having an upfront shared decision-making session as well as repeated sessions over time is important to continue to make sure the best plan that's been individualized to the patient is put in place. So I want to thank you so much for your time, for listening to my thoughts on cholesterol-lowering therapies. Aviva, thank you for the invitation.
And thank you, Dr. Martin, and thank you to our audience for tuning into this episode of Patient Pulse. And you can join us for another episode next month. Thank you.